Okay, let's start. Good morning, everybody. Good afternoon. Welcome to the Pan American Trauma Society and its BITE International Trauma Ground Rounds. This meeting has been happening for 14 years already, and today is the meeting every first week of the month. This meeting going to be sponsored in partnership with SBITE, and a case from Brazil for our SBITE friends is going to be presented. Bom dia a todos, bem-vindos ao International Grand Rounds. A reunião hoje é em parceria entre a SBITE e a Pan American Trauma Society. I would like to ask the Dr. José Parreira, SBITE's president, to introduce our friend Dr. Dinar Góes. They're going to be presenting the case today. Thank you, Parreira.
Thank you, Antonio. It's a pleasure for SBITE to be having this international round with you, with the Pan American Trauma Society. For us, it's a honor, and I'd like to thank you for this opportunity. And this month, our meeting will be presented by Dr. Adenauer Góes. Dr. Adenauer is a surgeon, a general surgeon, a vascular surgeon. He has his master and PhD in vascular injuries, specifically study shunts in vascular trauma in animal models. And Adenauer developed a very, very consistent and strong experience in vascular trauma working in Belém do Pará, which is a city in the north of the country. And there is a spot there, the hospital he worked, Metropolitano Hospital, is a hospital that receives patients from a very huge area from the Amazon. So he had a strong and very, very important experience to share with us, and he has already published many of these papers. So Adenauer, thank you for presenting this meeting. It's a pleasure having you here. And again, anyone who wants to make comments on the meeting, please raise your hands. I will be glad to call you.
Okay, thanks for the honor. I think I will start presenting my slides.
It's okay.
Okay, everybody receives that?
It's okay. Go ahead.
Okay, so we are going to talk about penetrating neck injury and the surprises that sometimes can come with these cases. So this is the case. A young man was stabbed in the right neck zone 2, and he arrived hemodynamically unstable with a profuse bleeding, obviously suggesting a vascular injury. And I prepared some slides with leads for interactions. And these slides are with the blue letters. So the patient arrived with a penetrating injury at this spot, profusely bleeding in the ER. And now I want to ask everybody, does anybody want to comment what could be done in the ER? Besides, of course, securing the airway, but regarding the bleeding, would anyone attempt to do something?
Well, it's open for discussion. Would like to comment, Dr. Ultrach. So we have
Yes.
zone 2,
Yes,
a lot of blood around. What do you do?
Yeah, zone 2 injury and with hard signs of an arterial injury. So you need to secure the airway and a couple of IVs and try to stop the bleeding. In this case, I would, assuming if he's bleeding from the wound externally, you could put your finger on the wound, see if that helps, or place a Foley catheter through the wound as far as it'll go, then inflate the balloon to get control over the injury. And at that point, you need to call for blood and then take him directly to the operating room. And on the way or preparing to do that, need to do a quick assessment of his chest and abdomen but while you're waiting to get things set to go to the operating room. But for the initial control of the bleeding, I think putting a Foley catheter through that wound would be a good first step.
Yeah. Dr. Spilassi also clearly. Dr. Adenauer.
I see there another colleague who wants to make comments.
Adenauer, are you listening to me?
Yes. Are you listening to me? Hello, hello.
Any other comments on that? No, now we're listening to you.
I see a colleague. I see a colleague has rose his hand. I don't know his name. Can you help me here? He wants to make a comment.
It's Dr. Horman, Horacio Horman. Please go
So,
ahead, Dr. Horman.
Nice to meet you.
nice to meet you too. I know that we always been trained to secure the airway. The problem I have with securing an airway in the ED and a patient who maintains his own airway is that if you don't know if the airway is compromised. I have seen patients where complete transection of the trachea in the ED. And if that were to happen and try to intubate in the ED is really not the right environment. I prefer if the patient can maintain, I would put local pressure, control the bleeding if I can control the bleeding. And after that, move the patient to the operating room and intubate in the operating room where I have more resources than I would have in the emergency department. I am also it's kind of unusual for me to disagree with Dr. Untrach, but I am kind of very reluctant of putting anything in a wound in the neck because you don't know where it can go. You don't know if it will be effective, and you might get this in a wrong place. Like, for example, if there is a connection with the trachea, you may end up with the catheter inside the trachea rather than in the artery that you want to tamponade. So I would do local pressure and move this patient to the operating room, have everything ready to open the neck and chest or whatever needs to be open at the same time that anesthesia does the induction. But that's my approach. I'm not saying it's the right one. It's what I do. Thank you.
This is a great discussion. This is a great discussion. Very updated. Dr. Albert Varon, please.
Yes, I'm an anesthesiologist, so obviously I'm concerned about the airway. So one question was not mentioned. You mentioned heart signs, you have bleeding, but the other one is subacute emphysema. So I would like to know if this patient has subacute emphysema, which would be probably the most sensitive indicator of airway injury.
I agree
Dr.
with you,
Adenauer?
but he had no signs of airway injury.
Okay, still being a zone 2, you really don't know what you have. So I agree with I think Dr. Hoffman mentioned, if your OR is close by, probably securing the airway in the OR would be the best approach. But as always, stop the bleed goes first. So I would do put a finger in the wound. Now, if that doesn't stop the bleeding, you can't let the patient exsanguinate. So a Foley catheter or any catheter, just to blow it up superficially, just to stop the bleeding. Again, finger will be better. Now, once the patient is in the OR, the problem everybody has is the patient going to be difficult to intubate? And that's actually not the answer. It shouldn't be the question. The question is, once the tube goes below the vocal cords, where is the tube going? Is it going to the trachea or is it going back into the esophagus? So an approach that we recommended 30 years ago that we do here at Ryder is if the patient can tolerate it, which is very few, we do an awake bronchoscopic intubation. Most of these patients can't. They think you're the one that stabbed them, so they are not going to let you do that. So we do what we call a rapid sequence. We used to call it fiber optic, but now those fiber optics don't have fibers, they're scopes. So we call it rapid sequence bronchoscopic intubation. And it's very simple. You just put the bronchoscope into the tube. And when you intubate with the scope before the tube gets railroaded over the scope. By doing that, you can assure, number one, you can do a quick review, make sure there's no blood in the airway, and then you can position the tip of the tube basically just above the carina. So if there was something, you just bypass it. But that's essential to make sure that, and we have seen it, the tube can go back into the esophagus if you have an esophageal injury. If there was no secure emphysema, it's unlikely. But for again, for penetrating injury, zone 2, rapid sequence bronchoscopic intubation probably is the safest approach in these cases. Once you have the airway secure, then yes, you can explore. You have hard signs. So a CT angio wouldn't be it's not part of the workup. If you have hard signs, you have to go to the OR. Thank you.
You're welcome. Very good comments. Thank you very much. Dr. Pilassi.
Hi. I totally agree with the comments that this patient is hemodynamically unstable could be a problem in terms of intubation, just because physiologically he might be a difficult airway. But I just wanted to raise a comment that zone 2 we've seen as well pneumothoraces from the same side or even from the other side, because we don't know the trajectory of these knives. So also to be considered if we're going to positive ventilate this patient, to make sure that he doesn't have a pneumothorax, or even if he's unstable and has a pneumothorax, to make sure we decompress it as to really take it out from our equation, even though we know he's bleeding from one side, but this could be adding into his hemodynamic instability. Thank you.
Great comments. Before going back to Dr. Adenauer, I would say that one of the worst scenarios I ever been through is one of these wounds that go through a carotid artery and goes inside the trachea, because the patient, there's a lot of blood from the airway, so there's no doubt it's bleeding inside from the artery injury to the airway, and this is a very, very difficult situation to control. So all of these comments, they are perfect in this scenario. Dr. Adenauer, you can go ahead.
Okay, thanks. I completely agree. Very good comments. And I probably should said in the beginning, but the truth is that I was not involved in the first assessment of this patient, and neither I was there when the surgery began, because I was doing an amputation in another operating room, and I entered the case after it had already begun. But I personally am a big fan of Foley catheters. And when you see this illustrative image in red letters, this is because it's not from the actual case, but from cases I want to show so we can discuss different strategies. So these are other cases where Foley catheters helped in junctional bleeding for temporary control, and of course, secure the airway. Like in this different case, if you can put a Foley catheter here and stabilize the patient and do an angio CT, like in this case, you can see the Foley catheter making the hemostasis and the blush from a branch of the subclavian artery. If the patient is stable enough and your facility has possibility to treat it by endovascular methods, which I didn't have at this hospital, even though I am trained in endovascular procedures and I do perform them, at this specific hospital, we don't have any endovascular resources. But if you can manage to stop this bleeding like this and stabilize the patient, you can proceed to the endosuite and make a branch embolization, for example. So back to the original case. So the patient was intubated in the ER. They didn't try to put the Foley catheter, and he was immediately taken to the OR, and this is the blood pressure, 90/50. And then the patient arrived to the OR. I was not the surgeon at that point. It was a friend of mine. And then again, the blue letters. So would you do anything before opening, before making an incision, assuming that no airway injury was detected, the patient is already intubated? And what surgical access would you choose to perform?
Open for discussion. Perhaps
Anybody?
Dr. Frisbee. Dr.
Yes.
Frisbee?
Yes.
No.
Well, you know, the surgical access depends on your choice. The external border, the sternocleidomastoid, you can start there, unless you've got some indication that the knife blade is going downward instead of straight across. I would start like I usually do at that point.
Okay, thank you. Dr. Untrach, any other idea?
Yes, I agree with Dr. Frisbee. I would prep from the chin down to the lower sternum and upper abdomen, and start with as Dr. Frisbee said, anterior to the injury is local right there. You should be able to get control in the low neck. If not, you can extend the incision to a median sternotomy and get control of the mediastinum at the, if need be, at the innominate or beyond the first bifurcation. But I would leave the option to go into a median sternotomy, and that would also give access to either chest, especially the right chest if you needed it.
I think Dr. Adenar can go ahead. We have a lot of things to discuss.
Thanks, but I completely agree. Well, if I didn't if I haven't inserted the Foley catheter in the OR, I would do this at the operating room. This is a second case, another case, but just to show how to do it, because some colleagues, some younger surgeons hadn't had this experience before. So sometimes you are able to put a Foley catheter like this and control the bleeding. And then we go to the surgical incisions. And basically, we have two axes for operating neck trauma. Many general surgeons prefer to do the number 1 incision. Many trauma surgeons and vascular surgeons that I know prefer to do the number 2 incisions. They have some differences, but in this case, the surgeon that was operating performed the number 2 incision, following the anterior border of the sternocleidomastoid, as discussed. And my colleague made this incision. These are 2 different cases. I think the only situation where I would perform the collar incision is for bilateral perforating injuries in a stable patient, because it requires to dissect under the platysma, and it takes some time to be done properly. And if the patient is unstable, I prefer to do what I did in the next case, or meaning a bilateral anterior incision that you can even communicate like a V, and it works very well. You can see this incision showing the esophagus, the internal jugular, the common carotid, the carotid bifurcation.
Okay.
So it makes a very good incision. And if you need additional exposure for lower injuries, if necessary, we can divide the sternal insertion of the sternocleidomastoid muscle like this. But getting back to the case, my colleague did the incision. No injury was found in the carotid, nor in the jugular. The patient received blood products, improved his hemodynamic status. The BP is now 11/7. And the surgeon number 2 was called for help. I was the surgeon number 2. I was finishing amputation, and I got into the case at this point. So they made the initial incision, and no injury was found in the neck. What to do next?
Was there bleeding, active bleeding, Dr. Boyce?
Yes, through the wound.
From where? From the
from
neck?
the wound, from the neck, from the side,
down in the mediastinum.
we didn't know where was the source, but it was out in the skin injury, right there in the neck zone.
Okay. Now we have a case, don't you?
Every
Okay,
time the residents took the finger out, gushing. But I could
Okay.
not dissect with that finger there. So,
Dr. Guilherme Barilaro, would you like to comment? Dr. Guilherme?
Gracias. Good case.
Dr. Pilasi made a comment on the chat. Proximal control on the chest. Okay, could you explain that better, Dr. Pilasi? How would you do that?
I think these, as it was rightly mentioned at the beginning, we have to have a trauma patient prepared on the chest, and I would probably even extend that to thighs to have access to in case we need saphenous. But in this case, for proximal control, I think we should go for if we have the capacity to do a sternotomy and have a proximal control, which would allow us to then remove that finger and have a look at what's happening.
Dr. Horman, raise your hand.
Dr. Untrach raised his hand before me.
Go
No,
there.
go ahead, Dr. Hockman. You go first.
Okay, so this is really what you don't want, really. I agree with Dr. Pilasi. Probably doing a median sternotomy and getting control of the innominate artery will be the way to go, because probably here is the beginning of the the subclavian going over the first rib. That would probably the injury happen, or maybe the vertebral artery or branch of those. The problem in that area is all the nerve structures that are going through there. So my question is, was this patient having a pulse in the right arm? And also, was he moving the right arm when he came in? The other possibility, the other thing you have to be worried is in front of this, you will have the phrenic nerve too. So it's really, it's where you don't want to be. So I don't envy your position there. But so did the patient have any neurodeficits or any vascular deficits on the right arm?
well, honestly, when I arrived there, the patient was already with neck open and intubated, being operated. And I just got into this fight, and I didn't examine the pulse in the right arm. And obviously, I didn't examine the neurological function because the patient was already intubated in the ER. But I agree with your comments very much.
Well, I like the idea of the vertebral injury. What would it be anything different for you, Dr. Untrach? Okay.
Well, yeah, I was going to say.
Mediastinal source, okay, you open the chest. But if you, in case you have a posterior bleed.
Yeah, I was going to say that before doing the sternotomy, you want to get a good idea which direction the blood's coming from, because if it's not the carotid and it's arterial blood, so if it's not the carotid artery, it could be the right subclavian or the innominate, but it could also be the vertebral artery. So you don't want to then go ahead and do the sternotomy and say, oh, no injury, so what next? So, and you said that the wound was tracking which way, inferiorly or superiorly, posteriorly? Which way was the finger pointed?
So at that point, I said to the resident, okay, take your finger out. I will put my finger in. And I realized the stab went downstairs. It went in the inferior way. So yeah, the vertebral, if it was injured, it would be at the first portion, just arising from the subclavian and not at the V2 segment.
Yes. So yeah. So I agree. You could do the sternotomy, or since the patient is now more stable, is he still tachycardic or normal sinus rhythm?
He was still tachycardic, about 110.
Yeah, because you
But
could
obviously much better than he was.
sternotomy is fine. You know, you can do a short sternotomy and a trap door, but then you'd also have to get distal control. So, you know, depending on where you think the injury is, you may just be able to expose the subclavian after it enters the axilla. You can take out the medial third of the clavicle if that's where the injury is, and you can get you can deal with the problem that way. You can avoid the sternotomy. But if there was any doubt and you needed to get rapid control, I agree. Just do the sternotomy, get control, and then determine where the bleeding is coming from. But it's very likely going to be from the subclavian in this case, and not the vertebral artery posteriorly.
Okay, go ahead.
Okay. Thanks. So I did inserted the Foley catheter at this time, and we managed to cease the bleeding. And then I decided to go to the subclavian vessels. I completely agree. If I could go back in time, maybe I could do something different and go straight to sternotomy. But at that time, the way my finger went and the way I was managed to control the bleeding, I decided to try to avoid the sternotomy and manage the things doing this access. So this is the actual photo of the case. So I inserted the Foley balloon through the skin injury. You can see there the umbilical tape was securing the common carotid artery, and only a limited exposure of the subclavian vessels was possible to be dissected without
Can you show us where the head and where the thorax is in the image?
I don't think my mouse would, when I move my mouse, it doesn't appears for me but if you can see
the right side, who looks at the picture on the right side, the picture is the head?
No, in the left side is the head.
Okay, now I understand.
You can see the clavicle. You can see the clavicle.
Okay.
Appearing. Okay.
That's strange because you put the Foley through the wound and not on the contrary, because you usually do it from the outside to the inside. So that's what's
when I put it, I try to put it through the wound, because when you have a profuse bleeding, the bleeding shows you the way, because it dissects the anatomical path. So you can go gently inserting the Foley, and sometimes you manage to put it in the right position. That's why I like so much this picture, because it's not easy to register a picture like this, to show how the Foley was inside, but it was inserted through the skin injury. Okay, so now I had a second problem. I realized exposing this way, I was not able to gain proximal control. And at that point, I thought, okay, the problem is the right subclavian artery or a big branch of this artery. And now I decided to do a sternotomy. So this is the final view of the thing. And of course, it's beautiful to do this when you have the electric saw, but sometimes you don't. And I pray all trauma surgeons not to forget how to use a jiggly saw, because sometimes it's all you will have. And this is another case. This was a shotgun into the precordium, but just to show how I like to do it, I like to pass first umbilical tape, and then I can do, I can see if it's going well, like this, before start using the jiggly saw, like this. But the fact is that once you have this open, some tips for exploring the mediastinum. So when you open this, you will find a very big hematoma. You don't know where the things are. It's like walking in the dark when you arrive late at night at home. So the first tip is to remember that the...
Dr. Collet raised his hand. Probably he's on.
Please, Dr. Collet, always nice to hear from you.
I try to see what you're doing, but I think the great problem here, you have a problem that this injury of the artery on the, or the veins, clavier vein, before the scaleniomuscles. So the proximal control you can make by this incision start with the section of the brachiocephalic trunk in front of the trachea. Then you can go to subclavian artery behind the two branches of the sternocleidomastoid muscle, and then you can approach, remove the clavicula. You can remove and approach this branch of the subclavia at this moment. And sometimes you not need to make a sternotomy in this case. The subclavian artery on the right side is more elevated and more easy to assess by only the cervical approach. We know that I make several sections like this. And this position, the great problem is if there is injuries of the vein, the subclavian vein, because when you open this, the subclavian vein, this patient is hypotensive patient, you have problem with air embolism from this patient because the big vessels, venous vessels, can make gas embolization in this position. It's very important to know what to do when you have injuries in this situation. You have to remember in this position that you can see section the scaleniomuscle, and then you can go side in, and then section the proximal portion of the subclavia, and then you go to the axilla of it section the subclavia, the artery, axillary artery on the near the branch. So you can sometimes in this situation you can avoid a sternotomy. It can be sometimes very difficult to do, and sometimes very problem and post-operative sometimes. So I think it's very important because I know that I have several cases and several sections of subclavian artery. That's the reason that I'm talking to speak. So I think it's very important to do. And normally the surgeon don't know this anatomic topics, but it's very important to knowledge and to know how to do.
Dr. Kassim,
I completely
Dr.
agree.
Kassim, I'm sorry, yeah. Dr. Kassim, would you like to comment? Would you open in this situation, have a huge hematoma in the anterior part of the mediastinum? What is your approach here?
Good morning. I've been listening to the experts talk about this case. There are a couple of things that I would have done a little differently. While you're intubating, I would have also done a bronchoscopy at the same time to rule out any airway injury while I'm getting ready to do what my next move is going to be. And I agree with the incision the surgeon chose initially, and I would not allow the resident to take his finger out till I deploy the Foley catheter right from the beginning. And the second thing, once the arterial injury, i.e. the carotids were noted not to be bleeding, the bleeding is coming from somewhere, and I would assume the patient, the man who stabbed this patient probably was left-handed. The knife probably went downwards towards the mediastinum, and having determined that, I think I would just remove the clavicle rather than wasting my time with a mediastinotomy. And I would remove the clavicle so I can get a panoramic view of the subclavian and the branches. And
Okay.
there would be, underneath that clavicle will be the area where the injury has occurred. It will be the branch of the subclavian, either the first part of the vertebral or one of the thoraco and cervical trunk, and that would have been my approach. I think I would go with what Dr. Collet just eloquently told us what he would do. Thank you.
Thank you very much. Denora, can you go ahead?
Yeah, I just want to say I know Dr. Collet personally, and I know he has one of the greatest experience with these accesses. But you know, sometimes in the rush of the moment, I had to decide, and I thought, okay, so first incision didn't go well, second incision didn't go well. I need to solve the problem. This is the last chance. So I decided to be more aggressively. And regarding take out the middle third of the clavicle, I am a very big fan of this strategy. But in this specific case, I realized in order to take the mid third of the clavicle, I would need to lose the Foley catheter. And then the bleeding could start again. So I decided to go to sternotomy. I think another colleague wants to make a comment.
Dr. Pilassi.
Yeah, just wanted to as reinforce a bit what Adenauer just said in terms of I'm a trauma surgeon, not a vascular surgeon, and I think maybe it's based on what the experience you have on getting access to subclavians. But we know the principle is proximal and distal control in vascular trauma. And if we tried something and we cannot go through the proximal bit, then the next step, I think the safest one and the quickest one is to do a sternotomy. I would have not tried anything else because I don't have a lot of experience with the subclavians, but I think if that failed, I would still need to do a sternotomy. So I'm just skipping one extra step and going straight and safe onto the sternum axis.
I agree. When I know the injury is near the transition between the neck and the thorax, sometimes I do a partial sternotomy in the shape of an upside down letter T. And it works very well when you only need access to the innominate artery. But at this case, it's easier, it's faster to do the conventional sternotomy than to do this partial sternotomy. And because the patient was unstable, I decided to go to the conventional sternotomy in this case. But anyway, when you arrive there, I will share some tips that I think are useful in this situation. So
Go ahead.
usually the anatomic field will not be the most beautiful one. There will be some hematoma there. And then if you partially open the upper part of the pericardium is your friend. It works like a barrier for the hematoma. And inside the pericardium, the anatomy will be preserved. And from there, you can locate yourself and get oriented and follow the dissection. The second thing is that the left innominate vein is the gatekeeper for the mediastinum. And frequently, you will need to divide and ligate this vein. So keep this in mind, because try to avoid putting a central line from the left side. I have had the experience to divide this vein, to find the catheter inside, and it is a nightmare. Because if you lose the distal end of the catheter, it goes right into the heart, into the atrium. So it's you don't want to create another problem. So if possible, try to communicate with the anesthesiologist and avoid that. Or put that, retrieve that before dividing the vein. And then you get access to the supra aortic trunks. It's not always necessary to divide the innominate vein, but if necessary, it gives you good access. So this is the actual case. I was able to preserve the left innominate vein. You can see there the structures numbered from 1 to 6. I will not spend a lot of time here just reading, but you can see that everything begins with the ascending aorta, and then you go to the innominate artery. The 3 is the common carotid, the 4 is the subclavian. You can see there the nerve and the internal jugular. And this is something I think we all should keep in mind. It's important to remember which arteries can be ligated, and actually, we can ligate a lot of them. You can ligate, if necessary, everything that is green. And you can see there's a difference from the left subclavian and the right subclavian. The right one is marked in red because this portion is after the origin of the vertebral artery. But if necessary, if you ligate the subclavian before the origin of the vertebral artery, you can get this. We call it subclavian steal phenomenon or subclavian steal syndrome. And if this patient, for example, had an injury in the origin of the left subclavian, and I did resuscitative thoracotomy and ligated the artery, and I follow up this patient for many years, and he has even left radial pulse palpable. So it's an interesting strategy for sometimes. And this is the actual case. The injury was in the origin of the tirocervical trunk, and it worked, it bled like a subclavian artery. You can see there the trajectory the blade made, passing just above the nerves. No nerve was injured. It was, I think, the man who stabbed him studied a lot of anatomy because it's dissected the nerves. And there is the injury, right exactly in the origin of the tirocervical trunk. But I swear you guys, it bled like it was a subclavian artery injury. And this is the pericardium partially opened, the ascending aorta, and all the vessels I have just shown you. This is the gatekeeper, the left innominate vein that I was able to preserve in this case. And the last tip, I completely agree. You never know what is the incision you will need to perform. And remember, I didn't start this procedure. When I got there, the surgical field was already prepared. And I strongly suggest you to put all the monitoring devices in the back of the patient, because if I need to extend, this would make my life much more difficult. So this is my last tip. And for those who have never been to the Amazon, I strongly invite you to know this interesting and beautiful part of the planet. Best regards from the Amazon, my friends. Thanks for this amazing opportunity. Martos and Parreira, thank you very much for this.
Hey, thank you. But you are going to escape us, this soon. We have a lot of questions. I'm certain people want to question, but I have one. If you are eventually in a situation that you have endovascular approach possible, and you have the catheter in that position, would you try something endovascular before opening the chest? Because you have this situation in which you have a bleeding, intraoperative bleeding, you have a mediastinum there, and there is a huge bleed from the deepest part. So you put a hand there, you put a finger, stop it, and go to the interventional radiology. What do you think about it? Would you do that?
I think it would be my dream to do that. And nowadays, the first line for subclavian injuries is endovascular, where it can be done. But this where it can be done involves personal, involves resources, materials, everything. For this injury, this specific injury that was almost in the subclavian, you had there 5 millimeters from the origin of the vessel to the subclavian. You are not able to embolize that, but you can put a stent graft there and solve the problem. Or if you don't have the stent graft, you can do an endoclamp. The endoclamp is a principle that you insert there a balloon by endovascular ways, inflate the balloon and cease the bleeding, and then you can dissect everything without bleeding. So if endovascular is available, I think it's a fantastic way to go.
Thanks. You have many people that liked your presentation here. Dr. Pilasi, beautiful dissection. Jorge from Rondônia, congratulations. Roberto Calderon, wonderful. Dr. Cassim asked if he could share the presentation with his residents. I'm sure you can, Dr. Cassim. Ana Gabriela asked us about the chest X-ray, but I'd like to say that if you have a situation like that, and for example, let's just figure we had once a common left carotid injury, exactly going from the arch, so it's a very proximal left. So if you can't control this bleeding, you are really in a situation. You will have to ligate it, control the bleeding, and make some kind of bypass. So the IR, I think, is very, very important if you are able to control and then study the anatomy before getting into it. That's the point. So it's open for discussion. Anyone would like to add some comment? I'm seeing Dr. Utrach.
Yes. So just to comment on your last point, Dr. Pereira, if you have an injury to the common carotid and there are other injuries or the patient's in bad shape or you don't have access to the equipment, I believe, especially in a young person, you could just ligate that with impunity because there'll be good perfusion through collaterals across the face from the upper side, and that should work. Anyway, I wanted to ask Dr. Goes, could you have actually gotten exposure to the proximal thyrocervical trunk through the other incision that you do, where you divide the insertion of the sternocleidomastoid into the clavicle? Would that have given you access to that area? And I guess those branches occur before the subclavian goes behind the anterior scalene muscle. Isn't that right?
Yeah, this is the access Dr. Collet suggested, and it would expose very well the injured site. But I felt in order to obtain proximal control, I didn't want to go straight there. I did want to get proximal control in the innominate. So from the innominate and the subclavian orange. So that's why I did this incision.
May I make a comment? That's why your nerves are preserved, because you go without knowing what's going on. You got clipping and cutting things. You probably had a injury to the brachial plexus, which is very common in this situation.
Yeah, of course.
Dr. Hortman.
Terrific case. Terrific case.
Thanks.
Ligating the innominate vein is usually the key, and this is many times, since if many people, like, I don't know, cardiac surgeons are very reluctant to do this, but in order to get good access there, you need to ligate the innominate vein and get it out of the way. Your comments about the catheter there was really very good. I always say that if there's something was done wrong or stupidly, I surely done twice. I have one worse. I had to do an emergency pneumonectomy for bleeding, and I cut through a Swangan's catheter that I didn't know it was there. So that's worse than cutting through the catheter on the nominated.
Now I'm feeling much better. Thank you for
Yeah.
sharing this.
I really love your giggly saw. I never thought about using the giggly saw for the sternum. We use the Levski knives that somebody mentioned in the chat there. They're cheap. We have it in the trauma bay. We have the regular saws in the operating room, but if you need to use as an emergency, the Levski knives work very well. But the giggly saw, I really love that tip, like many of the tips that today. Another one I think is excellent is open the pericardium to get the innominate artery. That's is another brilliant tip. And in the other thing I was going to mention is getting distal control infraclavicular. And I don't like this. This is something I learned during my training, and I find out that it's extremely fragile. They rupture very easily when you try to go around. So I got kind of scarred from those experiences. So I tried not to go there. I think that, as Dr. Pajeras mentioned, using an endovascular approach might be better, and you also mentioned, Dr. Ghost. But the subclavian access to the subclavian artery, I don't know what you think about this, but thank you, and terrific presentation. Thank you very much.
Dr.
Well,
Adenauer?
I think every time you have the chance to treat the subclavian and axillary transition, the proximal part of the axillary, every time it's able to be performed in endovascular treatments, that's the best way to do it. Because of the nerve injuries, it bleeds less. It's much better. But the problem is that in many countries, in many places, you won't have this chance. So if this access is necessary, my personal choice is to make an incision just over the clavicle, and then when you get to the deltopectoral, how to say, groove, deltopectoral groove, sulco deltopeitoral in Portuguese. You go there between the deltoid and the pectoralis muscle, and then you do a dissection without cutting. You do how do you say, Parreira? Divulsão. You make it
Blunt dissection.
Yeah. It's a
blunt dissection. Nice, blunt dissection. And then you get access to this transition. These arteries, they melt like butter. So if they are very fragile and they tear very easily, but if necessary, that's the only thing we can do.
Great comments. So, Dr. Martos, we are almost on 2 o'clock. Would like to make any comments, the final comments?
Tem gente do mundo todo, Kevin.
Yes, it's just a pleasure to see this nice group of people from everywhere in the world united here and discussing trauma case. A trauma case that could happen anywhere, and then we all take care the best way we can with the research that we have available in our hospitals, in our cities, in our states, in our countries, and using the expertise that we have. Not all the centers have the privilege to have Dr. Adenauer Góes as a vascular surgeon available to take care of this kind of trauma. So I follow his career and I know the knowledge that he has, the lectures that he gives, and how important is his work in the trauma care in vascular injuries. And well, it's just a privilege to have him here today sharing his experience with this case and with the other case. I truly believe this meeting has been going on for so many years, and we all stay learning, keep learning year after year, every single Monday with each other, how to treat the same kind of injuries in different countries, in different places in the world. That's just amazing. So I would just like to say thank you very much for everybody for participating. Thank you very much for SBITE to be supporting this meeting today. And it's just great to see our friends connected every Monday here. Okay, back to you, Dr. Parreira.
Dr. Martos.
Adenauer.
I I am deeply honored for receiving your compliments. It's an honor for me. And for those who are planning to come to Brazil in our meeting, Dr. Parreira and I, we are organizing a hands-on course on vascular injuries for those who are attending the Brazilian trauma meeting. And our goal there is how to teach the surgical access and especially the damage control for those who are not vascular surgeons, so they can be able to deal with these injuries. Thank you very much for this opportunity.
I'll be your first student. Thank you very much for that. Thank you very much for that, Dr. Adenauer, and everybody else. I think it's huge. Thank you very much for your tips, for your knowledge, for sharing your opinions. Well, everybody, every time we do this meeting, we go out better than we get in. So thank you very much.
And I would like to thank everyone who has participated and shared his own experiences, because we are always learning. The next time I will do something different, something better, because I learned something with also the more experienced surgeons that shared today. Thank you very much.
Thank you. Dr. Matos, next.
Thank you a lot.
WST, is that correct?
Next Monday, Pan American WST meeting, yes. I'm going to have a case from Dr. Salamea from Peru, from Ecuador, another case. So going to be two cases with very nice discussion as well. Thank you all.
Thank you all. See you.
See you. Bye-bye.
Bye-bye.
See you, Tony.
See you, Frisbee.